So my topic for the day will be, so first of all, good evening friends, and it's really regretful Dr. Goswami's presentation was one of the ones that we were looking, all of us were looking forward to. So my presentation for the evening was SACROILIAC joint injections. It's not moving. Wow. Coming to the clinical application of this, as we all know, sacroiliac dysfunction leading on to pain is a common etiology of back pain, forming about 10 to 27% of all mechanical low back pains. Patients at risk for this are mostly patients with limb length discrepancy, increased age, patients with inflammatory arthritis, pregnancy, trauma, and patients with previous spine surgeries. The indications for this particular injection, they can be given both as a diagnostic as well as a therapeutic procedure. In case of diagnostic blocks, about 75% of pain relief is generally establishes the diagnosis. And in case of therapeutic blocks, both intra-articular as well as peri-articular injections have been described. However, intra-articular injections have been found to be better efficacious. Contraindications, as usual, as for other injection procedures, relative contraindications being coagulopathy, pregnancy, systemic or local infection, and uncontrolled diabetes. Coming to the applied anatomy of the joint, as Anindo had already previously mentioned, I think Anindo as well as Shumayon. So it's an auricular-shaped diarthrodial joint having a hyaline cartilage on the sacral side and fibrocartilage on the iliac side. The innervation, it is controversial as very elicited by Shumayo. However, the pain generators are mostly the is actually enters the joint from the posterior aspect and comes from the lateral branch of the sacral dorsal rami. These are the nerves that are targeted by the injections and are blocked. So taking a transverse section of the sacral joint, we see that there is a posterior and a medial aspect of the joint in the transverse section, and the anterior and the lateral aspect. That is, the anterior side is actually lateral to the posterior side. So when we enter posteriorly, which is the approach to this joint in case of injections, the target is the posterior medial joint line. So coming to the technique, firstly, after consent and expectations of the procedure has been explained, the patient is put in the prone position. C-arm is taken contralaterally to give us AP, oblique, as well as lateral views. We have to remember that the capacity of the joint is about 2 ml. Just a word in here. Am I audible or?
Audible.
Yes, you are perfectly audible.
Yeah, so
yes, audible.
Thank you. So the capacity of the joint is about 2 ml. So in order to confirm the positioning of the needle, a maximal amount of about 0.5 ml of the contrast is generally injected so as to keep space for the eventual steroid in case we are aiming for a therapeutic injection. So this is, these are the diagrams. So the patient has been put in the prone position. A pillow is kept under the ASIS. Generally, the person who will be injecting, in this case me, is standing on the opposite side of the concerned joint. The C-arm is kept on the ipsilateral side, and the screen is kept at the ipsilateral side foot end. So that arrow actually marks the screen side. After skin preparations, the markings on the skin are done preoperatively. The PSIS are mostly palpated and marked. However, a PIIS, a lesser important landmark, are generally not, they cannot be palpable most of the time and are marked on the skin under C-arm guidance. Now, if you look at that star that is there on the lower diagram, which just came on, that is generally the entry point as when you take the PSIS and PIIS, the location of the entry point is generally that star mark, and that is what the target is. Coming to the C-arm positioning, generally you can see the head end and the foot end in the patient. Generally, the C-arm is put in an oblique AP about 10 to 15 degrees. So 10 to 15 degrees oblique in order to elongate the joint line. And as you can see the X-ray picture, so that's the anterior. Okay, that's a mistake. So the anterior is actually the posterior joint line and the posterior is actually the anterior joint line. The posterior joint line is medially placed. So this again is a better view. So you can see a needle in the anterior joint line, right there, I'm sorry. An oblique view showing and confirming the placement of the needle in the anterior joint line. And this is the lateral view. I'll come to this in the video again. In the lateral view, which is basically the safety view, the only thing that we have to keep in mind in this case, the only structures that we are liable to injure in this particular procedure lies anteriorly, that is the so-called viscera. So this lateral view is the one which is the safety view, and we need to take it in order to make sure that the needle has not progressed inadvertently. The needle, as you can see in the lateral view again, is upward directed, and obviously we don't go ventrally. And this is an optimal image. About 0.2 to 0.5 ml of the contrast has been injected, and you can see how it delineates the joint. Both the anterior as well as the posterior joint line has been demarcated. If there is any resistance in case of while we are advancing the needle, generally we rotate the needle first, and if still there is any resistance, we generally advance or withdraw the needle slightly before injecting whatever is there in the needle. These are a few examples of suboptimal image. The first one, you can see the contrast has leaked anteriorly and is pooling outside the joint. The second one, you can see the contrast in the soft tissue and is evident from the nature in which the contrast has actually flowed. So these are some of the videos we have taken. This is up. I'll pause it there. This is like the patient is in prone position, as I showed in the positioning picture. So under fluoroscopy, I'm trying to put in the needle. Needle has been put into the target in trajectory view, keeping the C-arm in EP. Okay, that is confirming that the needle is inside. I'll just now show the C-arm pictures again. I mean, after this. Okay, this is how the joint, the needle has been going in. It is, okay, that's the AP view. And once it is inside, we basically turn the needle on both sides, about 10 to 15 degrees oblique on either side to confirm it is inside the joint. Then we take a lateral view to make sure that the needle has not gone ventrally. And this is eventually, once we are happy with the position of the tip of the needle, we attach the extension tube and try to make sure again with the help of contrast. Here I generally clamp the needle so that to prevent any further advancement of the needle. Okay. So the contrast has been put in under fluoroscopic guidance. Disconnecting the contrast syringe. And then we go laterally just to make sure that the contrast is in the desired position and has not leaked ventrally. This is what we see once this is the needle is inside, and you can see once we inject the contrast how beautifully it delineates the joint line. Okay, and now once we are happy with the contrast, we generally inject the steroid. That is about how the technique is. Coming to a few complications, minority of patients very, very rarely can present with an immediate transient vasovagal reaction. However, the most common is an hello?
Yes, continue.
Most common being an increased pain and soreness of the SI joint for a short duration. We have to remember that there is a failure rate of about 10%. Very rare complications, however, more serious ones, are trauma to the nerves. Sometimes the patient can complain of bilateral lower leg weakness because of an inadvertent intervertebral foraminal injection, a hematoma, sciatic palsy, meningitis, infections, or even pyogenic sacroiliitis have been described, but as I said, very, very rare and serious. So thank you very much.